Welcome dear students, this is Dr. Pratyusha and in this video let us learn about the assessment of hearing. So assessment of hearing is broadly done under two categories. First is clinical methods and second is audiometric methods. This is an important topic because hearing loss is one of the main complaints in the ENT department. So whenever a patient approaches us with a complaint of hearing loss, we must first assess the hearing to proceed any further. Let us study about the clinical methods of testing. Under clinical methods, we have some very basic tests such as finger friction test, which means just snapping the finger close to the ear of the patient and asking if he can hear or not. It's very basic and almost obsolete now. It is like asking a person with vision to, showing fingers and asking if he can see or not. It is that basic and in fact obsolete. The second test that we do is watch test. We take a watch where the second hand is clicking. It makes a clicking sound and we put that watch in the room or close to the patient and ask if he is able to perceive those clicking sounds. Even this test is very basic and it is almost obsolete. Third is the speech test. Speech test as in the examiner speaks a few words and asks if the patient can hear. How this is done is normal conversations, the patient should be able to hear from a distance of 12 meters. Normal conversation should be heard from a distance of 12 meters. And whispers must be heard from a distance of 6 meters. But for the purpose of the test, what we do is, for both of them, conversation and whisper, we take the distance to be 6 meters. So the patient is seated here and here is the examiner and the distance between both of them is 6 meters. 6 meters distance is there. Then what we do is, there is another assistant. Suppose we want to check the right ear of the patient. The examiner stands towards the right side of the patient, 6 meters away from the patient, and there is another assistant who closes the left ear of the patient by applying pressure on the tragus. That's how the left ear is occluded. And only the right ear is checked. Suppose if you want to check the left ear, then the examiner is towards the left side and the assistant closes the right ear. And then we try to do the test in a calm and noiseless surrounding as much as possible. And another thing that we do is we close the eyes of the patient so that there is no provision for lip reading. And then the examiner uses spondy words or alphanumeric combinations, numbers with letters. Normal day-to-day conversations such as how are you, what is your name is not done in this test. We use spondy words or numbers with letters as in X3A, BF4, 6CD. Alphanumeric combinations like that. These words are uttered by the examiner and the patient should be able to hear them and repeat. From a distance of 6 meters, if the patient fails to listen and repeat, then the examiner moves closer and closer and at whatever distance he hears, we mark that distance. So the problem with this test is there is no standardization of the loudness of voice of the examiner and the pitch of the voice. And also we cannot guarantee about the ambient surroundings, the noisy surrounding or whether it is calm or peaceful. So these are all the drawbacks and disadvantages of this test. So even this is not a reliable test. What we actually do and most important among clinical assessment is the tuning fork tests. Tuning fork tests are actually performed and they give us a lot of insight into the hearing assessment of the patient. So let us see what is done in a tuning fork test. A tuning fork is taken. It's an instrument that we all know that produces sounds upon vibrations. And it has designated frequencies. On the tuning fork, you can see some numbers written, and that shows the frequency of that particular tuning fork. So we have tuning forks ranging from 128 Hz, that is, it makes 128 cycles per second. 256, 512, 1024, 2048, and so on. But what we apply under clinical scenario is the 512 Hz tuning fork. That is most ideal in a clinical setting. So tuning fork measures both the air conduction and the bone conduction of the patient. Now, as we all know, hearing is done by two mechanisms. Air conduction is through the sound travels through the external auditory canal, tympanic membrane, middle ear ossicles, and then it goes into the inner ear, into the cochlea. This is the air conduction mechanism. Bone conduction mechanism is the sound travels transcranially via the bones and directly reaches the cochlea. But what we have to understand is air conduction is always better than bone conduction. Because in air conduction, the middle ear does the job of impedance matching and it amplifies the sound. And this effect is missed in bone conduction. So always for a normal person, air conduction is better than bone conduction. So with this understanding, let us see how tuning fork is used to test air conduction and bone conduction. We take a tuning fork and put it into vibration by gently tapping it on the palm of the hand or on the elbow of the examiner. Then the tuning fork starts vibrating and we put that tuning fork about 2 centimeters away from the external auditory canal of the patient. And this is used to test the air conduction of the patient. Then what happens is, if the patient happens to hear that sound, we are testing the entire conduction pathway, the external auditory canal, tympanic membrane, middle ear ossicles, and also the sensorineural part. Even the cochlear function is tested. If we want to check bone conduction, then what we do is we take that vibrating tuning fork and put it on the mastoid antrum of the patient. Then transcranially the sound is transmitted and it directly goes to the cochlea. So we are testing only the sensorineural part. If we put it away from the external auditory canal, 2 centimeters from the external auditory canal, we are checking air conduction plus the sensorineural part. Please remember and understand this. Whereas if we put it on the bone, we are only checking the sensorineural component. So let me write this down anyways. It is used to check air conduction and bone conduction, and always remember, air conduction is better than bone conduction. This is something that should always be known and understood. Air conduction is better than bone conduction. That is normal. So when we are checking air conduction, we put the tuning fork a little away from the external auditory canal. We are checking the entire conduction pathway, the intactness of the conduction pathway, plus the sensorineural component also. Whereas, when we are checking for bone conduction, we are only checking the sensorineural component, that is the cochlear function. I hope this is clear. Now with this basic understanding, let us move into specific tuning fork tests. So first among them is Rinne's test. Rinne's test. In Rinne's test, we compare the air conduction versus bone conduction. So what we do is, we take a vibrating tuning fork and place it over the mastoid of the patient first, and then we ask him until when he is hearing, and after the patient stops hearing, then we put it in front of the external auditory canal and asks if he can hear the sound now. If the patient still continues to hear the sound via air conduction, then it is understood that air conduction is better than bone conduction. Otherwise, alternatively, if the patient has to communicate to you that he has stopped hearing the sound, and then you should quickly move it to the front. If all this is not properly done, another method that we can use is we can ask the patient when is he able to hear better, on the bone or in front of the ear. So a normal patient will tell air conduction is better than bone conduction. That is, he is able to hear better when the tuning fork is placed in front of the external auditory canal than placing it directly on the mastoid antrum. This is in a normal person. So what we do is, first put it over mastoid antrum, and when the patient stops hearing, then put the tuning fork in front of the external auditory canal after the patient stops hearing. And ask the patient which is better, or we can just compare the loudness, which is longer or which is loud and better. In case the inference of this test says air conduction is better than bone conduction, AC stands for air conduction and BC stands for bone conduction. If the patient says air conduction is better than bone conduction, the patient will not say air conduction and bone conduction. The patient says this is better or this is better. And you can obviously understand. If the patient says air conduction is better than bone conduction, then two things are possible. Either the patient is normal. He has no hearing loss. As we know, air conduction is better than bone conduction in normal people. Or another possibility is present, he is having sensorineural hearing loss. Now, why would a patient of sensorineural hearing loss say air conduction is better than bone conduction? Because when the sound is traveling via the middle ear apparatus, the sound is amplified. So he tends to hear better. Because the sensory, now please understand, when I say sensorineural hearing loss, it doesn't mean the labyrinth is totally dead. There is some hearing loss only. The cochlea is still functioning, it is still working, but he is able to perceive only louder sounds. So when the sound is traveling via the middle ear apparatus, it is amplified, and so the patient hears better than bone conduction, where sound is directly going to the cochlea, and so he happens to hear less. So when air conduction is better than bone conduction, it means that either the patient is normal or the patient is having sensorineural hearing loss on the side where you are testing. If the patient says bone conduction is better than air conduction, then it means that the patient is having conductive hearing loss, conductive deafness. There is some problem either in the external auditory canal or in the tympanic membrane or in the middle ear ossicles or some other problem in the middle ear, or eustachian tube is not functioning properly. Till that point, there is some problem in the conducting pathway, that is conducting deafness. So this is about Rinne's test. We can gain much more information from Rinne's test, that is by using multiple tuning forks. I'll tell you how. So when a patient says bone conduction is better than air conduction, he is having at least a hearing loss of at least 15 to 20 decibels loss is there. Otherwise, Rinne cannot capture that. At least 15 to 20 decibels loss should be there. In a patient with just 5 to 10 decibels loss, Rinne will not say bone conduction is better than air conduction. Okay. So, first we check with a tuning fork of 256 Hz. At 256 Hz, the test is negative. Test is negative means bone conduction is better than air conduction. If air conduction is better than bone conduction, then the test is said to be positive. If bone conduction is better than air conduction, then the test is negative. So at 256 Hz, the test is negative, and at 512, it is positive. What does that mean? As the frequency increases, hearing becomes better. As the frequency of the sound increases, it becomes more and more sharp and hearing becomes better. So at 256, the patient is not able to hear, but at 512, his air conduction and bone conduction is same. That means he is having a hearing loss of approximately 20 to 30 decibels. Next scenario that is possible is, the patient is having negative Rinne Test at both 256 and 512 Hz, but positive Rinne at 1024. What does that mean? That means the patient is having a hearing loss of 30 to 45 decibels. Next scenario is, the patient is having a negative Rinne at all frequencies 216, 256, 512 and 1024 also. This means he is having a hearing loss somewhere ranging between 45 to 60 decibels. These might appear just like numbers, but it is possible that these questions are asked in the exam. It's not possible, it has been asked in fact. So let us figure out a way to remember this. Now conceptually, at 256, the patient is telling bone conduction is better, and at 512, he is telling air conduction is better. That means only 20 to 30 decibels loss. Now at 256 also, he is telling bone conduction better, 512 also bone conduction better, only at 1024, his air conduction is better than bone conduction. That means he is having somewhere between 30 to 45 decibels. At 256, 512, 1024 and all these three frequencies also, if the patient says bone conduction is only better, then he is having a higher hearing loss somewhere between 45 to 60 decibels. So conceptually you have understood that as the frequency increases, he should be able to hear better with air conduction. And if he is not able to hear with higher frequencies also, that means he is having more and more hearing loss. The direction of progression you have understood, right? So how to remember the numbers is, just remember 256 corresponds to 15 decibels loss, 512 corresponds to 30 decibels loss, and 1024 corresponds to 45 decibels loss, broadly. So 256 negative means he is at least having 15 decibels hearing loss. 512 negative means at least having 30 decibels loss. 1024 is also negative means he is at least having 45 decibels loss. This much, these three numbers at least we can memorize, right? So you will be able to answer questions, if at all, to such depth if they are asked. Now we have to learn about another entity called as false negative Rinne test. What is false negative Rinne test? Negative Rinne means bone conduction is better than air conduction, and we assume that the patient is having conductive type of hearing loss. But there is another scenario possible where the patient is having severe unilateral sensorineural hearing loss. Then what happens is, suppose I am checking for the right ear and the patient is having severe sensorineural hearing loss in the right ear. Suppose say his labyrinth is dead labyrinth. Then what happens is, first I am checking for air conduction and the patient cannot hear anything, and then I am checking for bone conduction, patient says I am able to hear something. And you think it is conductive hearing loss, but no, actually what happened, the entire labyrinth is dead, but when you are checking for bone conduction, This side cochlea gets activated through transcranial spread. Apart from this cochlea, even the opposite side cochlea receives some sound impulses and the patient happens to hear something. And so he says, I'm able to hear something with bone conduction, and we assume it is negative Rinne, but this is actually false negative Rinne's test. So when the patient says bone conduction is better than air conduction, it means that either the patient is having conductive type of hearing loss or the patient could be having severe sensorineural hearing loss on that side. So air conduction is also negative, the patient is not able to hear on air conduction also and bone conduction also. He is actually able to hear from the other cochlea when we are testing for bone conduction. This is known as false negative Rinne's test. So with this, we complete all about Rinne's test, and I hope it is clear. The next test is Weber's test. Weber's test. In this, what we do is, we are checking for bone conduction only. We take a vibrating tuning fork and we place it upon the forehead of the patient, or you can also put it on the vertex. And then we ask the patient, which side are you able to hear better? Right side or left side or equal? A normal patient who is having equal hearing on both the sides will say, I am able to equally hear on both sides. When you put it on the center, it goes both ways and the patient will say equal hearing on both sides. A normal person will say equal on both sides. Yes. Now second situation is the patient says, I am able to hear better on one side. Now if the sound is lateralized to either one side, there are two possibilities. If the patient says he is able to hear better on one side, that is, there is lateralization of sound to one side, there are two possibilities. Lateralization happens in two scenarios. One is, it is lateralized to the worse ear in conductive hearing loss, and it is lateralized to the better ear in sensorineural hearing loss. Let us understand what these statements mean. When we are doing Weber's test, basically we are checking for bone conduction. And in bone conduction, what we check is sensorineural component of hearing. So if the patient is having sensorineural hearing loss on the right side, the sound will be lateralized to the left side because this sensorineural component is not working and it is working on the other side. So the patient says, I am able to hear better on the better side. Suppose the patient is having, this is clear, in sensorineural hearing loss, the sound goes to the better side. Suppose the patient is having conductive type of hearing loss. Then what happens is, in this ear, say suppose there is conductive hearing loss and we are checking for bone conduction. In this ear, what happens? Conduction is good, sensory neural component is also good. So the patient is able to hear some external ambient sounds also while we are checking for the tuning fork. So these external ambient sounds will dampen the direct sound coming from the bone conduction, from the tuning fork. But this side, the conducting pathway is damaged, so the patient cannot hear the outside ambient noise, and so the bone conduction is perceived better. Because there is no noise effect on the side where there is conductive type of hearing loss, the patient happens to hear the sounds coming from the tuning fork better than the opposite ear. So this is the concept. Let us study with examples for better understanding. Say this is the right ear and this is the left ear. And let us see various possibilities. If at all the patient says equal, that means both are normal. If the patient is perceiving sound towards right ear, what does that mean? It means the patient is having sensorineural hearing loss of left ear. We are checking for bone conduction and left ear sensorineural component is not working, so automatically the sound is transmitted to the right ear. Or the patient is having conductive type of hearing loss of the right ear. Then also he says sound is lateralized to right ear. Why? When there is conductive type of deafness, the noise effect is not seen, and so he hears better with the right ear. Bone conduction of right ear is better than the opposite ear, which is able to hear both the sound from tuning fork and also external ambient noises. So in these two conditions, patient says lateralized to right ear. When is the sound lateralized to left ear? Opposite, when there is sensorineural hearing loss of right ear. Then sound is lateralized to the left side. Or when there is conductive hearing loss of left ear, then also the sound is lateralized to the left side. Now it is possible that the patient can have conductive type of hearing loss in both ears. Right side also there is a problem, left side also there is some problem. Say right ear conductive hearing loss around 30 decibels. Left ear conductive hearing loss around 45 decibels. Now what happens? What does our rule say? In conductive hearing loss, it is always lateralized to the worse ear. Which among these is worse ear now? Right side 30 decibel loss, left side 45 decibel loss. So left is the worse ear. So in this situation, the sound is lateralized to the left side. Why? Because right ear 30 decibels only loss is there. Some external sound it is still able to pick up. Left ear 45 decibels loss. The ambient noises that are picked up are very little. Bone conduction goes better towards left side. Okay. And opposite, if the right ear conducting loss is more than the left ear, then Weber's is lateralized to the right side. So here comes our rule, that is worse ear in conductive hearing loss. Now next scenario, let us say the patient is having sensorineural hearing loss in both the ears. Right ear sensorineural hearing loss is say around 70 decibels. Left ear sensorineural hearing loss is around 50 decibels. Just arbitrary numbers I am using. Then which side is Weber's lateralized to? Both ears there is sensorineural hearing loss. What does the rule say? Better ear in sensorineural hearing loss. So which is the better ear here? It is the left ear. So sound is transmitted to the left side. Yes. Why? Because we are directly checking for bone conduction and hearing loss on the left side is 50 decibels, hearing loss on the right side is 70 decibels. Straight case, obviously it will go to the better side. Simple as that. Now let me make it slightly even more difficult, because these are all clinical case scenarios being asked. Okay. So the patient is having a right ear conductive type of hearing loss and a left ear sensorineural type of hearing loss. Which side is the sound lateralized to? Right side conductive hearing loss. So which side should the sound go? Right side. Left side sensorineural. So which side should it go? Opposite side, that is right side. So in this scenario, The sound is lateralized towards the right ear. Another possibility, right ear sensorineural hearing loss and left ear conductive hearing loss. Now which side should the sound go? Right side sensorineural. So obviously it will go to the left side. Left ear also conducting. Based on that rule also, it conducting worst side, conducting hearing loss, it should go to the worst ear. So left ear is conducting hearing loss. So it should be lateralized to the left ear. I hope after seeing all these clinical scenarios and various permutations and combinations, we have covered all of them. I hope Weber's is clear. So Weber's gives you an idea whether it is which ear that is having conducting loss and which ear is having sensory type of hearing loss. Next clinical test is, third clinical test is with the tuning fork, absolute bone conduction test. Absolute bone conduction test. Also known as ABC. So as the name suggests, we are checking for bone conduction. It is a measure of cochlear function. We are measuring the sensorineural component. So how do we perform this test is, the bone conduction of the patient is compared with bone conduction of examiner and their external auditory canal is occluded. This is most important. We are not taking the effects of conductive hearing. Now that is what is happening in Weber's, right? Some external noise is disturbing, and that is why even though conductive hearing loss is there, bone conduction is becoming better on that side. So to avoid all that, what we are doing is we are occluding the external auditory canal, pressing upon the tragus and occluding it. And then we are absolutely checking only the bone conduction of examiner versus bone conduction of patient, assuming the examiner has normal hearing. Then what happens is, if the patient is normal, then both the examiner and patient will perceive for the same duration. What we do is, we take a vibrating tuning fork and put it upon the mastoid antrum of the patient, and take another vibrating tuning fork and put it upon the mastoid antrum of the examiner. And when the bone conduction is normal in both of them, they both hear it for the same duration of time. Same duration of time. If at all the patient is having sensorineural hearing loss, then what happens? The examiner hears it for a longer time and the patient hears it for a shorter time, because we are checking bone conduction, and bone conduction is a measure of the sensorineural component. So if the patient is having sensorineural hearing loss, he hears it for shorter duration than the examiner. This is about this test. Go back. And if the patient is having conductive type of hearing loss, then also he hears it for the same duration of time as the examiner, because we have occluded the external auditory canal and we are not taking into effect any ambient noise, or the conducting mechanism is not being tested here. So whether the patient is normal or he is having conductive type of hearing loss, he will hear it same as that with that of examiner. If the patient is having sensorineural hearing loss, then he will hear it for a shorter duration. There is another test, that is Schwabach test. In Schwabach test also, the bone conduction of patient is compared with the bone conduction of examiner. So what is the difference between Schwabach test and absolute air bone conduction test? In absolute bone conduction test, the external auditory canal is occluded, and here there is no occlusion of external auditory canal. So let us see how this will change the results of the test. If the patient is normal, then the patient and the examiner will hear it for the same duration of time. If the patient is having sensorineural type of hearing loss, then the patient will hear it for a shorter duration of time than the examiner. Yes, because we are checking for bone conduction and his sensorineural component is affected. So, and the examiner is normal, so he hears it for a shorter duration than the examiner. Now, the difference between absolute bone conduction test and Schwabach comes when the patient is having conductive type of hearing loss. When he is having conductive type of hearing loss, his bone conduction becomes better than air conduction. While for the examiner, air conduction is better than bone conduction because examiner is normal. So when his bone conduction is better than air conduction, then what happens is the patient hears it for a longer time than examiner. Say after 10 seconds the examiner says, I stopped hearing, the patient will still continue to hear because his bone conduction is even better than the examiner's bone conduction. Why? Because there is conductive hearing loss, there is no ambient noise, and bone conduction, there is no noise picking, sound picking. The ear is not able to pick external sounds, and so bone conduction is better than air conduction. So these are the results of Schwabach test. He hears it for longer time than the examiner also in conductive type of hearing loss. Next we have two more tests. Fifth one is the Bing's test. In Bing's test also, we are checking the bone conduction. But the special feature of Bing's test is, we are checking the effect of occlusion of external auditory canal on hearing. So what we do in Bing's test is, we take a vibrating tuning fork and place it on the mastoid antrum of the patient, and we keep occluding and opening the external auditory canal by applying pressure over the tragus. Press and release, press and release. And we ask the patient what is he able to perceive. So a normal person, when the external auditory canal is occluded, then his bone conduction becomes better. In a normal person, hears better when external auditory canal is occluded. Yes, when there is no external sound, bone conduction will be heard better. A person with conductive type of hearing loss will perceive no such difference. Whether we occlude the canal or open it, anyhow the conducting pathway is damaged, so he doesn't perceive any difference. In a patient with sensorineural hearing loss, he happens to hear better the external auditory canal is occluded. Why? We are checking for bone conduction, and when the external auditory canal is occluded, there is no external sound, and so the sensory component becomes better. So he hears better when external auditory canal is occluded. So we put a tuning fork and keep on pressing and releasing the tragus, and if at all he hears better when the external auditory canal is occluded, that means the patient is normal or he is suffering from sensorineural type of hearing loss. If the patient perceives no such difference, same type of hearing when the canal is occluded or it is kept open, then it means that the patient is suffering from conductive type of hearing loss. And the last type of tuning fork test is Jelly's test. In Jelly's test also, we are checking for bone conduction. But what is the special feature of this test is, we are seeing the effect of increased pressure in the ear canal on hearing. What does that mean? Normally, when the pressure inside the ear canal increases, pressure inside the external auditory canal increases, the tympanic membrane is pushed inwards and all the ossicles are also pushed inwards. So the pressure inside the labyrinth, the tympanic membrane pushes the malleus, incus and stapes, and the stapes foot plate is also pushed inwards. So the inner ear, the intralabyrinthine pressure increases. When the intralabyrinthine pressure increases, the basilar membrane becomes immobile and so hearing is reduced. This happens normally. So let us see the normal mechanism. When pressure in external auditory canal is increased, the tympanic membrane plus the ossicles move inward, and this will increase the intralabyrinthine pressure. And when the intralabyrinthine pressure increases, there is immobility of the basilar membrane. Immobility of basilar membrane. What is basilar membrane? Where the organ of Corti is situated. The main sensory receptor for hearing is situated on the basilar membrane, and when the basilar membrane becomes immobile, then final result of this entire situation is hearing is reduced. This happens normally. So what we do is, we take a vibrating tuning fork and place it on the mastoid antrum of the patient. And how to increase the pressure in the external auditory canal? There is an apparatus called as Siegel's speculum. With that speculum, we can alter the pressure in the external auditory canal. So what we do is, with the other hand, we take a Siegel's speculum and increase the pressure in the external auditory canal. And based on all the sequence of events that I just explained, what happens in a normal person? When pressure is increased in the external auditory canal, hearing is reduced. In a normal person. In a person of sensorineural hearing loss also, the same thing happens. Hearing is reduced. As such, cochlea is not functioning properly. On top of that, because of all the increased pressure and immobility of basilar membrane, hearing is reduced. But if the patient is having ossicular chain problem, suppose there is ossicular chain fixation, or discontinuation. Say the malleus is attached to incus and incus is attached to stapes normally. Because of some reason, say a middle ear infection or something, one of the bone in between is necrosed totally. No incus is present in the patient. Or there is fixation of ossicles. The ossicles are not mobile, as we see in otosclerosis. Discontinuation or fixation is there. In those scenarios, what happens is we increase the pressure, tympanic membrane moves inwards, and that will move the malleus, but then everything is fixed. So these do not move the stapes footplate inside and they do not increase the intralabyrinthine pressure. So what happens is the patient will not perceive any difference. Hearing is not reduced. Normally hearing is reduced when we increase the pressure, but in patients with ossicular chain fixation or ossicular chain discontinuation, the patient does not say hearing is reduced. No reduction of hearing. No reduction of hearing. This is negative Jelly's test. Negative Jelly's test. These two are positive Jelly's test. So negative Jelly's test is seen in a disease called as otosclerosis. Star mark question. In a clinical scenario where otosclerosis is given, they will mention this point that the patient's Jelly's test is negative. Usually this is the classical disease that we see where Jelly's is negative. So this is all about clinical tuning fork tests. It's a topic that requires a little understanding. So once in a while you might need to pause, ponder, think again and logically understand. So I will summarize everything that we have learnt in one table. Before that, a question to you. Air conduction is checked only in Rinne's test. In rest all tests, we are checking bone conduction only. Please understand that. If at all there is a question that air conduction is tested in, answer is Rinne's. In all the other tests, we are checking for bone conduction. And Rinne's positive means air conduction is better than bone conduction. In Weber, there is nothing called positive or negative. It is equal on both sides or lateralized to one side. In absolute bone conduction test, there are two results, that is either same with that of as that of examiner or shorter than that of examiner. In Schwabach test also, there are two results possible. There are three results possible in Schwabach test, same as that of examiner, shorter or longer. In Bing's test, bone conduction is tested and there are two results. Here again we say positive and negative. In Bing's test, we have positive and negative. Bing's is said to be positive when the patient hears better when the external auditory canal is occluded. So it is positive in a normal person and it is positive in a person with sensorineural hearing loss also. And it is negative in a patient with conductive hearing loss. That is when the patient says there is no difference. In Jelly's also positive. Jelly's is positive in a normal person and in a patient with sensorineural hearing loss. And it is negative in a patient with ossicular chain fixation or discontinuation. So let us summarize everything in one small table. I shall write down all the test names on one side. First is Rinne's test, Weber, absolute bone conduction, Schwabach test, Bing and Jelly. And the three broad scenarios that we know are either the patient is normal or the patient is having conductive type of hearing loss or the patient is having sensorineural hearing loss. These are the three scenarios possible. So let us see what happens in each of them. Rinne's test when performed on a normal person, it is positive. That means air conduction is better than bone conduction. Rinne's test when performed on a patient with conductive hearing loss, it is negative. That is, bone conduction is better than air conduction. Because conductive hearing loss, the amplification of sound by middle ear is not there, so bone conduction is better. If at all the patient is having sensorineural hearing loss, then also Rinne's is positive. Because here also air conduction is better than bone conduction. When the sound is traveling via the air through middle ear, there is amplification of sound and the patient happens to hear better via air conduction than bone conduction. This is about Rinne's. Very simple and easy. In Weber, when performed on a normal person, there is equal hearing on both sides. In a patient with conductive hearing loss, it is lateralized to the same side. Lateralized to same side. That is, whichever side there is disease, or it is lateralized to worse ear. If at all the patient is having sensorineural hearing loss, then it is lateralized to opposite ear or to the better ear. What is same ear or what is opposite ear? The ear in which there is problem. So suppose there is sensorineural hearing loss on the right ear. Left ear is the opposite ear. The patient happens to hear better in the opposite ear, in the better ear. Absolute bone conduction test, where the bone conduction of the patient is compared with the bone conduction of the examiner while occluding the external auditory canal. So a normal person will of course hear same, equal to that of examiner. A patient with conductive hearing loss will also hear equal to that of examiner. Why? The external auditory canal is anyways occluded. We are only checking the effect of bone conduction. So when he is having conductive hearing loss, that doesn't come into account. We are only checking for sensorineural component. So when the patient is having sensorineural hearing loss, he hears it for a shorter duration than examiner. Shorter duration than the examiner. Schwabach test. Bone conduction of patient is compared with the bone conduction of the examiner, and the external auditory canal is not occluded. It is kept open. So on a normal person, when this test is performed, there is equal hearing with that of examiner. When it is performed on a patient with conductive type of hearing loss, next is Schwabach test, where the bone conduction of the patient is compared with the bone conduction of the examiner, but the external auditory canal is not occluded this time. So when it is performed on a normal person, it is same as that of examiner, equal as that of examiner. But when the patient is having conductive type of hearing loss, then what happens is, he happens to hear longer than that of examiner. It is better than that of examiner. In conductive type of hearing loss, the bone conduction becomes better. So he hears it longer than that of the examiner. In sensory type of hearing loss, if the patient is having sensorineural hearing loss, then he hears it for shorter duration than the examiner. Because bone conduction is affected and we are checking for bone conduction, examiner will obviously have a better bone conduction when the patient is having sensorineural hearing loss. So the only difference between absolute bone conduction test and Schwabach is, in conductive hearing loss, the patient will perceive no difference in absolute bone conduction test, whereas in Schwabach test, the patient happens to hear for a longer duration. Then in Bing's test, where the effect of the occlusion of ear canal is checked, then on a normal person, Bing's is positive. That is, the patient hears better when external auditory canal is occluded. In a patient of conductive type of hearing loss, even when the external auditory canal is occluded, there is no improvement in sound because there is conductive hearing loss as such. So this patient perceives no difference. There is no change. In a patient of sensorineural hearing loss, when the external auditory canal is occluded, the bone conduction becomes better. So it is positive. That is, it is better when external auditory canal is occluded. And last and final is the Jelly's test. When pressure is increased in the external auditory canal, hearing is reduced. That is normal. So Jelly's is positive in a normal person, that is decreased hearing on increased pressure. In conductive type of hearing loss, no such difference. Actually, conductive type of hearing loss in the sense ossicular discontinuity or ossicular fixation, when this increase in the pressure of external auditory canal is not being transmitted to the inner ear. Some problem in the conductive pathway, then there is no such difference by the patient. There is no decreased hearing on increased pressure because this increased pressure is not being transmitted to the inner ear. In a patient with sensorineural hearing loss also, the test is positive, that is decreased hearing on increased pressure. As such, there is some problem with the cochlea, and when we increase the pressure, the intralabyrinthine pressure increases, basilar membrane becomes immobile and hearing becomes reduced. Patient is having problem with cochlea also, so it further reduces in a patient with sensorineural hearing loss. So this is the summary of all the tuning fork tests, and I have a small cheat code for you. Generally, the findings in a normal person and the findings in sensorineural hearing loss are same, except in absolute bone conduction test, where the findings in normal and conductive type of hearing loss are same. Otherwise, if you observe, Rinne's is positive in normal also, positive in sensorineural hearing loss also. Weber, of course, it's a different scenario. Schwabach's also, it is same in normal and shorter duration in sensorineural hearing loss. In Bing's test also, it is positive in normal, positive in sensorineural hearing loss. Jelly's is also positive in normal, positive in sensorineural hearing loss. But absolute bone conduction test, it is equal in normal person and equal in conductive type of hearing loss, whereas it is heard for a shorter duration in a patient with sensorineural hearing loss. Generally, normal and sensorineural go hand in hand, and conductive hearing loss is in the opposite side. Otherwise, there are three different scenarios. Like in Weber, equal in a normal person, lateralized to the worse ear in conductive hearing loss and lateralized to the better ear in sensorineural hearing loss. And whereas in Schwabach's also three different scenarios. In a normal person, the patient hears same as that of the examiner, and in conductive hearing loss, he hears it longer than the examiner, and in sensorineural, he hears it shorter than the examiner. Absolute bone conduction, normal and conductive hearing loss, both of them will hear equally. Sensorineural hearing loss person will hear it for a shorter duration. And Bing's test is positive in both normal and SNHL. Jelly's is also positive in both normal and sensorineural. So with this, we complete the tuning fork tests. I hope you have understood various tuning fork tests and their interpretation. Mainly, we can differentiate between conductive and sensorineural type of hearing loss with this. And with Rinne's, we can also quantitatively estimate the hearing loss roughly by using different frequency tuning forks. Thank you very much.